So we're going to speak today about sonography of the urinary bladder, the scrotum, and the prostate. And we're going to start off with the urinary bladder. As you probably know, the urinary bladder's primary function is to serve as a reservoir for the urine so that you can accumulate the urine and then urinate at one time and then accumulate more urine. The bladder capacity for most people maxes out around 400 cc's. So 400 to 500 cc's is usually the maximum bladder capacity that we'll see. On a full bladder, you should be able to calculate that volume. On a post-void, you want to see the bladder empty completely so that there's less than about 10 cc's left in the bladder, and normal values are post-void residual of less than 5 to 12 cc's. When that post-void residual is greater than 50 cc's, that's called remarkably abnormal. For the purposes of ultrasound, we look at the bladder in sagittal and transverse orientations, and then we use the measurements that are obtained, measurements that are transverse measurements and then craniocaudal and anterior-posterior measurements to calculate the volume of the bladder. And you see here the formula that we tend to use, which is the pi over 6 times length times width times height formula to give us our bladder volume. And so this is the full bladder, and here is the post-void bladder, where after voiding you see that the bladder volume is much smaller and the wall appears thicker. But we use the same formula to calculate the post-void residual. So here's another patient where we see the full bladder is the slides here on your left, and then the post-void bladder is the slides on your right. Transverse measurement here before voiding, craniocaudal and anterior-posterior measurements before voiding, and this is a relatively normal bladder volume, but post-void we see that there's still quite a large residual, and the post-void residual will be calculated as this 8 times 6 times 7 times pi over 6, and you would find that the post-void residual is well over 50 cc's. So the two most common reasons for an increased post-void residual would either be bladder obstruction or outlet obstruction, most commonly related to an enlarged prostate, or an urogenic bladder. Now, when we look at the bladder wall, the wall of the bladder should be smooth and thin. In general, the bladder wall should be less than 5 millimeters in thickness, and we like to measure that bladder wall with the urine as a nice anechoic contrast to the wall, and then with the bright fat and back of the bladder here showing you where the other side of the wall is the outside of the wall. So this is bladder wall here, and this is a thick bladder wall measuring 7 millimeters. Now obviously this bladder wall is measured when the patient has a full bladder. Once again, a thickened wall, if it's diffuse thickening, we could be talking about outlet obstruction or a neurogenic bladder. That could be diffusely thickened and often appears trabeculated. When we're talking about a neoplasm, frequently the thickening is focal, it's irregular, and it's mass-like. We'd like to talk now about some of the variations that one sees in bladders. Bladder diverticulum is a common variation. It's not normal, but it's relatively common. Often bladder diverticula appear right here in the posterior lateral aspect of the bladder on one side or on the other, and they appear in those areas because there's a relative weakness in the bladder wall adjacent to the ureteral insertion. These are called Hutch diverticula, and the bladder diverticulum basically is a space that holds urine, and it's relatively stagnant urine, so it serves as a nidus for infection. But in addition to that, the bladder diverticulum does not contain a full thickness of the bladder wall, so it's the mucosa which is herniated through the muscularis. Because of the fact that there's no muscular lining outside here, if there's a tumor in a bladder diverticulum, it will spread very early, as opposed to we're having to first grow through the bladder wall before it spreads. The urachal diverticulum is a congenital variation where the urachus, which is a normal embryological structure, does not involute, and it persists throughout the patient's life. And so what you see here is a persistent urachal remnant. In this case, it's a diverticulum because it ends right here above the bladder. But the urachal remnant is always at the dome of the bladder, it's always in the midline, and it always pours toward the umbilicus. It may be just a diverticulum, as we see here, urachal diverticulum, or it may actually be a sinus tract where it extends all the way up to the umbilicus, or it may not communicate with the bladder, in which case it will be just a urachal cyst sitting out here by itself. In this case, this is a urachal diverticulum. Once again, there'll be stasis of urine in this diverticulum, so it can serve as a nidus for infection. But the cancers that occur in urachal diverticula are different than the cancers that occur in the bladder, because the bladder is generally lined by transitional mucosa, whereas the urachus is lined by columnar mucosa. So what you'll see here is adenocarcinoma in the urachus as opposed to a transitional carcinoma in the bladder. Another congenital abnormality which can interfere with bladder function is the ureterocele. Now, as the ureter comes through the bladder wall to empty into the bladder, it comes through an area which we call the ureterovesical junction. Sometimes there's an outpouching of the wall of that ureterovesical junction which goes into the bladder. And that saccular outpouching into the bladder is called the ureterocele. You can see part of the ureterocele here. You can see the ureterocele here on this transverse image of the bladder. These result in obstruction of ureters. They can result of stasis of urine, which results in infection. Now, ectopic ureteroceles, that is a ureter associated with the ureterocele that does not insert into the normal UVJ, but it inserts into an ectopic location, that's often associated with the upper pole of a duplicated collecting system. And in fact, what often happens is that the upper pole of that kidney is obstructed, related to the ureterocele, and the lower pole refluxes because there's some abnormality of the UVJ in the lower pole. This is another case of a ureter coming into the bladder, and you see here a smaller ureterocele associated with this ureter. Moving on to some other abnormalities of the bladder. A slide here on your left shows you bladder stones. So here you have the bladder with two echogenic foci, each showing distal acoustical shadowing, and these are stones within the bladder. If you ask the patient to turn or to move, you can visualize that these stones will move in the bladder. If one turns on the color Doppler, one can actually see a twinkle artifact, which is an aliasing type of artifact in the Doppler signal coming down from calcified stones. This mass, which is protruding to the bladder here, this is simply what we call median lobe hypertrophy from an enlarged prostate bulging into the bladder. So we were talking about stones within the bladder. Once the stones get into the bladder, usually they're not symptomatic, but on their way down to the bladder, they can be very symptomatic, and usually they get stuck in the ureter and often in the distal ureter. So here's an image of a ureter coming down to the bladder. This is the bladder, and this is a stone which is stuck in the distal ureter. You can see the bright stone with the shadowing. They often get stuck right here at the UVJ, ureterovesicular junction, and this can be extremely painful until it's passed into the bladder. But this is the grayscale image, and this is the color Doppler image of that stone showing you that same twinkle artifact. This is a transverse image of the bladder showing you the grayscale of the stone right here. When one's talking about stones, often one would like to know whether or not the bladder, the ureter is obstructed by that stone. And so here we see a way of evaluating whether the ureter is obstructed. This is transverse images of bladder. This is the right UVJ giving you a ureteral jet, and here's the left UVJ giving you a ureteral jet. And visualization of these ureteral jets documents that urine is passing unobstructed through the UVJ into the bladder. One should see a relatively symmetric amount of flow, so at least 2 to 3 jets per minute from each side. Overall, you should see something on the order of 4 to 6 jets per minute. You can see slightly more if the person is overhydrated, or you can see slightly fewer if the person is dry. But if you look at a bladder for a couple minutes and don't see any ureteral jets from one side or the other, that really suggests that that side may be obstructed. Likewise, if you see a constant low level of dribbling as opposed to a nice jet coming out of one side, that would also suggest that that side is obstructed. So looking into the bladder now, here's another patient. This patient actually is post-prostate biopsy, and this is a transverse view and a sagittal view of the bladder. And what we see is that there is a focal mass in the bladder, and this actually is a patient turned onto his side, and that mass moves to the side. And so what you see here, this is a big hematoma which is present in the bladder post-void. So this is one type of bladder mass. Two additional examples. This is one patient with diffuse thickening of the posterior aspect of the bladder. And here's another patient with a very focal mass inside the bladder. And both of these are transitional cell carcinoma. Transitional cell carcinoma generally presents as a focal mass or an irregularity. This might be more difficult to recognize, but you should at least see that this is not diffuse thickening of the whole bladder wall, but it's just sort of this posterior and superior portion of the bladder here that appears thickened. That's the tip-off that this is a mass lesion and not just thickening associated with outlet obstruction. Just another example, because this is such an important topic. This is a mass in the bladder. It's a focal mass here. This mass actually happens to be centered beautifully to obstruct this left ureter. And here you see the image of the left ureter labeled to the bladder, and there's a mass here. And so the other ureter was patent where this ureter was obstructed. And here is the mass here at the left UVJ. And here is the ureteral jet from the right UVJ. So we can see the flow coming in on the right side, but there is no jet coming on the left side. What you do see on the left side is there's Doppler flow within the mass. So this is a hypervascular focal mass obstructing the left ureter, and that was a transitional cell carcinoma. This is that same mass with a Doppler flow in sagittal imaging.